In this video, we are going to cover pericarditis. The pericardium, also called pericardial sac, is a double-walled sac contained in the heart and the roots of the great blood vessels. The pericardium is made up of two main layers, a tough external layer known as outer fibrous layer or the fibrous pericardium, and a thin internal layer known as the inner serous membrane or visceral pericardium or serous pericardium. The pericardial space between these two layers normally holds 10 to 15 ml of serous fluid called pericardial fluid. The pericardium anchors the heart, provides lubrication to decrease friction between heart contractions, and helps prevent excess dilation of the heart during diastole. And also, it separates the heart from interference of other structures, protects it against infection and blunt trauma, and lubricates the heart's movements. What is pericarditis? Pericarditis is a condition caused by an inflammation of the pericardium or pericardial sac, often with fluid accumulation. Pericarditis usually develops suddenly and may last from weeks up to several months. The condition usually clears up after 3 months, but sometimes attacks can come and go for years. Sometimes there is extra fluid in the space between the pericardial layers, which is called pericardial effusion. Pericarditis causes swelling and irritation of the pericardium, often causes sharp chest pain. The chest pain occurs when the irritated layers of the pericardium rub against each other. Pericarditis often is mild. It may go away without treatment. Pericarditis may be a primary illness, or it may develop in the course of a variety of medical and surgical disorders. Pericarditis may be acute or it can be chronic. Types of pericarditis. Diseases of the pericardium present clinically in 4 ways. They are acute pericarditis, pericardial effusion, cardiac tamponade, and constructive pericarditis. Patients can subsequently develop chronic or recurrent pericarditis. Acute pericarditis occurs when the inflammation of the pericardium that develops suddenly, along with the sudden onset of symptoms. Acute pericarditis begins suddenly but doesn't last longer than 4 weeks. Future episodes can occur. It may be hard to tell the difference between acute pericarditis and pain due to a heart attack. Pericardial effusion is an outpouring of fluid into the pericardial cavity seen in pericarditis. Cardiac tamponade is an acute type of pericardial effusion in which the heart is compressed either by blood or by a penetrating injury so that its normal function is impeded. Constructive pericarditis is a severe form of pericarditis in which the inflamed layers of the pericardium become stiffened, develop scar tissue, thicken and stick together. Chronic inflammatory thickening of the pericardium compresses the heart so it is unable to fill normally during diastole. Constructive pericarditis interferes with the heart's normal function. This usually happens after multiple episodes of acute pericarditis over time. Recurrent pericarditis occurs about 4 to 6 weeks after a bout of acute pericarditis. No symptoms happen in between. Chronic pericarditis occurs when the inflammation of the pericardium that lasts for 3 months or longer after the initial acute attack. Chronic constructive pericarditis usually develops slowly and lasts longer than 3 months. The specific symptoms depend on the type of pericarditis. Pericarditis is grouped into different categories according to the pattern of symptoms and how long symptoms last. Incessant pericarditis lasts about 4 to 6 weeks but less than 3 months. The symptoms continue over this whole time. Infectious pericarditis develops as a result of a viral, bacterial, fungal, or parasitic infection. Idiopathic pericarditis. Pericarditis that doesn't have a known cause. Traumatic pericarditis develops as a result of an injury to the chest. Uremic pericarditis develops as a result of kidney failure. Malignant pericarditis develops as a result of cancer growing in the body. Difference between myocarditis and pericarditis. Both of these are types of inflammation in the heart, but they are in different places. Myocarditis is in the heart muscle. Pericarditis happens in the pericardium. Most often, a virus causes myocarditis and pericarditis. Both can cause chest pain, but with pericarditis, the chest pain should feel better when sit up and lean forward. With myocarditis, clients usually feel tired and weak. There are many causes of pericarditis. The causes of pericarditis is often hard to determine. In up to 90% of cases, the cause of pericarditis is unknown and may not be found. When this happens, it is called idiopathic pericarditis. Pericarditis causes can include infection, usually viral, rarely bacterial or fungal. The following are some of the underlying causes or associated with pericarditis. The infectious causes. Bacterial. A bacterial infection including pneumococci, staphylococci, streptococci, Neisseria gonorrhea, meningococci, Legionella, pneumophila, Mycobacterium tuberculosis, septicemia from gram-negative organisms causes bacterial pericarditis. Lyme disease is a bacterial infection that can be spread to humans by infected ticks, also can cause pericarditis. Fungal. A fungal infection can cause fungal pericarditis. For example, Histoplasma candida species. A complication of a viral infection, most often a gastrointestinal virus, causes viral pericarditis. Coxsackie A and B viruses, echoviruses, adenoviruses, mumps, hepatitis, Epstein-Barr, varicella zoster, human immunodeficiency viruses, all these can cause pericarditis. Parasite. An infection from a parasite causes parasitic pericarditis such as toxoplasmosis. Next is non-infectious causes. Immune system response after heart damage due to a heart attack or heart surgery. Other names for this include Dressler syndrome, post-myocardial infarction syndrome, post-pericardiotomy syndrome, and post-cardiac injury syndrome. Neoplastic disease caused by metastasis from lung cancer or breast cancer, leukemia, primary neoplasms, that is mesothelioma, Hodgkin lymphoma, non-Hodgkin lymphoma. These all can cause malignant pericarditis. Trauma due to chest injury, percutaneous treatment such as cardiac catheterization or radiofrequency ablation, and heart surgery including pacemaker implantation, thoracic surgery, injury to the chest such as after a car accident, causes traumatic pericarditis. In these cases, it is likely that the inflammation of the pericardium is an error in the body's response to the procedure or condition. It can sometimes take several weeks for infection of myocarditis to develop after bypass surgery. Connective tissue disorders like periarthritis nodosa, polyarthritis, gastrointestinal diseases such as ulcerative colitis, Crohn's disease, and Whipple disease, these all can cause pericarditis. Disorders of adjacent structures, myocardial infarction, dissecting aortic aneurysm, pleural and pulmonary disease, that is pneumonia, these all can lead to pericarditis. Rheumatologic diseases or autoimmune diseases can cause pericarditis. Rheumatoid arthritis, rheumatic fever, systemic lupus erythematosus, systemic sclerosis, ankylosing spondylitis. These all can cause pericarditis. Metabolic disorders such as uremia, hypothyroidism may cause pericardial effusion, not necessarily pericarditis. Genetic diseases such as familial Mediterranean fever can cause pericarditis. Some medicines such as seizure treatment phenytoin, and medicines called procainamide to treat an irregular heartbeat, hydralazine, it is an antihypertensive drug, ionic acid is used to treat and to prevent tuberculosis. These all can cause pericarditis. Medications that suppress the immune system is a rare cause of pericarditis. Asbestosis may induce pericardial as well as lung lesions. Hypersensitivity states like immune reactions, medication reactions, serum sicknesses, these all can cause pericarditis. Radiation therapy also can cause pericarditis. Now we will see the pathophysiology of pericarditis. Cardiotropic viruses usually spread to the myocardium and pericardium hematogenously and cause acute inflammation with infiltration of polymorphonuclear leukocytes and pericardial vascularization. Polymorphonuclear leukocytes are one of the main sources of enzyme responsible for tissue damage in inflammatory processes. This may cause pericardial effusion and fibrinous changes of the pericardium. The pericardial effusion is the buildup of extra fluid in the space around the heart. If too much fluid builds up, it can put pressure on the heart. The pericardium may also develop a serous or hemorrhagic effusion. Most patients with viral pericarditis recover completely with few developing recurrences. Some patients develop constrictive pericarditis, which could be disabling. Frequent or prolonged episodes of pericarditis may lead to thickening and a decreased elasticity that restricts the heart's ability to fill properly with blood. In constrictive pericarditis, pericardial non-compliance creates a stiff ventricular pericardial unit, leading to increased diastolic pressure and more rapid rise in ventricular pressure for a given venous return. The non-compliant pericardium limits ventricular relaxation and determines ventricular diastolic pressure, resulting in elevated, equalized diastolic pressures in all chambers. Clinically, this presents predominantly as right-sided congestion with the signs and symptoms of jugular venous distension, edema, and ascites. Elevation in pulmonary capillary wedge pressure and a decreased cardiac output response to exercise results in dyspnea and effort intolerance, although frank pulmonary edema is less common than typical systolic heart failure. Pericarditis can lead to an accumulation of fluid in the pericardial sac and increased pressure on the heart, leading to cardiac tamponade. The pericardium may become calcified, further restricting ventricular expansion during ventricular filling, that is called diastole. With less filling, the ventricles pump out less blood, leading to decreased cardiac output and signs and symptoms of heart failure. Restricted diastolic filling may result in increased systemic venous pressure, causing peripheral edema and hepatic failure. Clinical manifestations of pericarditis. The most characteristic symptom of pericarditis is chest pain. Pain is present in anterior chest, aggravated by thoracic motion, may vary from mild to sharp and severe. Pain is located in precordial area, may also located beneath the clavicle, in the neck, or in the left scapular region. The pain or discomfort usually remains fairly constant, but it may worsen with deep inspiration and while lying down or turning in bed and twisting the body. It may be relieved with a forward leaning or sitting position. The most characteristic sign of pericarditis is a friction rub. Pericarditis friction rub is a scratchy, grating, or creaking sound rub heard most clearly at the left lower sternal border, occurring in the presence of pericardial inflammation. Patient may have fever, sweating, chills due to inflammation of pericardium. Other signs may include increased WBC count, anemia, and elevated erythrocyte sedimentation rate or C-reactive protein level, non-productive cough or hiccough. Dyspnea and other signs and symptoms of heart failure may occur as a result of pericardial compression due to constrictive pericarditis or cardiac tamponade. Edema, ascites, and dyspnea from pericardial effusion and cardiac tamponade may be present. Dysarrhythmias, palpitations, anxiety, or fatigue may be present. Swelling in the feet, legs, and ankles or shortness of breath every time client exhales may be a symptom of constrictive pericarditis. This is a severe type of pericarditis where the pericardium gets hard and or thick. When this happens, the heart muscle can't expand, which keeps the heart from working as it should. The heart can become compressed, which makes blood go back into the lungs, abdomen, and legs, leading to swelling and causing symptoms of congestive heart failure. Client can also develop an abnormal heart rhythm. Clinical manifestations of cardiac tamponade. The blood pressure may fall from normal, venous pressure may be high, and distant heart sounds with pulses paradoxes may be present. How to diagnose pericarditis? Sharp pain in the chest and back of the shoulders that feel better when clients sit up and lean forward and adjustment with breathing are two major clues that client may have pericarditis and not a heart attack. The rubbing of the pericardium's inflamed lining causes a rubbing or creaking sound called the pericardial drum. So listen to the heart. They will be able to hear it best when a person leans forward, hold the breath and breathe out. Depending on how bad the inflammation is, hearing crackles in the lungs are signs of fluid in the space around the lungs or extra fluid in the pericardium. There are a variety of ways to check for pericarditis and any complications such as pericardial effusion or constrictive pericarditis. A person may need one or more tests such as chest X-ray. Chest X-ray is to see the size of the heart and any fluid in the lungs. Electrocardiogram to look for changes in the heart rhythm. Echocardiogram is to see how well the heart is working and check for fluid around the heart. Cardiac MRI is to check for extra fluid in the pericardium, pericardial inflammation or thickening or compression of the heart. Sometimes a contrast is used during this highly specialized test. CT scan is to check for calcium in the pericardium, fluid, inflammation, tumors, and disease of the areas around the heart. Doppler imaging and color M mode can assess diastolic function and diagnostic constitutive pericarditis. Cardiac catheterization to get information about the filling pressures in the heart. This test can confirm a diagnosis of constrictive pericarditis. Blood test can help the provider make sure client is not having a heart attack, see how well the heart is working, test the fluid in the pericardium, and help find the cause of pericarditis. If client has pericarditis, it is common for the sedimentation rate and ultrasensitive C-reactive protein levels to be higher than normal. Common laboratory findings include WBC count and differentially indicate inflammation. Antinuclear antibody serologic test elevated in lupus erythematosus. Purified protein derivative test positive in tuberculosis. ASO titers are elevated if rheumatic fever is present. Blood urea nitrogen is to evaluate for uremia. Elevated cardiac biomarkers. Troponin levels may be increased in patients with ST segment elevation and acute pericarditis, which could indicate concurrent heart damage. Pericardiosynthesis is done for examination of pericardial fluid for etiologic diagnosis, and also it is used to get relief from cardiac tamponade. Pericardiosynthesis is usually done for pericardial effusion with acute cardiac tamponade, purulent pericarditis, or suspected cancer. The procedure is done rapidly and safely using a percutaneous approach guided by echocardiography. A needle is inserted into the pericardial space to remove fluid for analysis and relieve heart pressure. Fluid obtained during pericardiosynthesis or tissue from a pericardial biopsy may be studied to determine the causes of pericarditis. Now we will see the management of pericarditis. The objectives of management are to identify and treat the underlying problem and the symptoms, administer therapy, and be alert for cardiac tamponade. When the cardiac output is impaired, the patient is placed on bed rest until the fever, chest pain, and frictional rub have subsided. Analgesics and non-steroidal anti-inflammatory drugs such as aspirin or ibuprofen may be prescribed to control the pain and inflammation during the acute phase. They also hasten the reabsorption of fluid in the patient with the rheumatic pericarditis. Colchicine is an anti-inflammatory drug also be used as an alternative medication. Corticosteroids may be prescribed if the pericarditis is severe or if the patient does not respond to NSAIDs. Corticosteroids are used for patients with pericarditis from systemic lupus erythematosus, patients already taking corticosteroids for autoimmune conditions, or patients who do not respond to NSAIDs. Antibiotics are used to treat bacterial pericarditis such as penicillin or other antimicrobials. Rheumatic fever also be treated with penicillin G and other antimicrobials. Tuberculosis are treated with antituberculosis drugs. Fungal pericarditis are treated with amphotericin B and fluconazole. Systemic lupus erythematosus are treated with corticosteroids. Renal pericarditis are treated with dialysis, biochemical control of end-stage renal disease. Neoplastic pericarditis are treated with intrapericardial installation of chemotherapy, radiation therapy. Emergency pericardiocentesis should be done if cardiac tamponade develops. Pericardiocentesis is a procedure in which some of the pericardial fluid is removed, may be performed to assist in the identification of the causative agent also. It may also relieve symptoms, especially if there are signs and symptoms of heart failure. A pericardial window, that is a small opening made in the pericardium, may be performed to allow continuous drainage into the chest cavity. Surgical removal of the tough encasing pericardium, that is pericardiectomy, may be necessary to release both ventricles from the constrictive and the restrictive inflammation. Partial pericardiectomy or total pericardiectomy for recurrent constrictive pericarditis to be done. Complications of pericarditis. The major complications are pericardial effusion and cardiac tamponade. Effusion is a buildup of fluid in the pericardium. Cardiac tamponade develops as a pericardial effusion, volume increases and compresses the heart. Cardiac tamponade is a pressure on the heart due to fluid buildup. Other complications include heart failure, hemopericardium, especially patients receiving anticoagulants after MI. Hemopericardium is accumulation of blood in the pericardial sac of the heart.